Welcome to this explainer, everyone. Today, we're diving deep into the literal framework of the human body. We're going to break down the structure of a long bone, focusing specifically on its gross anatomy. Whether you're a nursing student, a medical student prepping for clinicals, or really just someone fascinated by how our bodies are built, this explainer is tailored perfectly for you. We're going to systematically peel back the anatomy of the bone step by step, so you can walk into your exams and your future practice with absolute confidence. Here's our roadmap for today. We're going to cover long bone anatomy basics, look at the outer and inner bone layers, explore the medullary cavity and marrow, trace the blood supply and nerves, hit some essential clinical correlations, and wrap it all up with a quick revision and some multiple choice questions. Let's get to it. All right, starting off with section 1, long bone anatomy basics. So, first things first, what exactly is a long bone? By definition, it's a dense, hard bone that is, you guessed it, longer than it is wide. But it's really not just about the shape, right? It's about what it does. These are the heavy lifters of your skeleton. They are perfectly designed to give you structural support, incredible strength, and of course, mobility. Think of the femur in your thigh or the humerus in your upper arm. Keep these practical examples in mind. If you're ever in an exam or a viva, just dropping the femur or humerus as an example is a surefire way to show you've got this foundational concept locked down. Now, if we scan one of these bones from top to bottom, you'll see it is divided into 3 distinct anatomical regions. First is the diaphysis. That's your strong, tubular central shaft, basically the primary weight-bearing pillar. Then, capping both ends of the bone, you have the epiphysis. These are the expanded, rounded ends that fit smoothly into your joints. And nestled perfectly in between the diaphysis and the epiphysis is the metaphysis. Now highlight this in your mind because the metaphysis is incredibly important. It contains the epiphyseal plate, which you probably know as the growth plate. This is the exact site of longitudinal bone growth in children and adolescents, making it a huge, highly testable exam point. Moving right along to section 2, outer and inner bone layers. Imagine we're doing a dissection, peeling the bone back layer by layer from the outside directly into the center. Step 1 is the periosteum. This is a tough, living outer membrane, and it's anchored tight to the bone by strong little structures called Sharpie's fibers. Just beneath that, step 2 is the compact bone. That's the really dense, hard outer cortex. Then, for step 3, we hit the endosteum, which is a delicate lining inside the internal cavities. And finally, in the core, for step 4, we find the spongy bone, a beautiful, porous internal network. It is actually fascinating how clearly these two bone tissues contrast. On one hand, you have compact bone, your heavy armor. It's incredibly dense, forms that tough outer cortex, and it is entirely responsible for structural support and resisting bending forces. On the other hand, you have spongy or cancellous bone. Unlike the solid cortex, spongy bone is lightweight and highly porous. It's made up of this delicate branching web of bony spicules called trabeculae. Because it's full of holes, it is not meant to take the brunt of your body weight alone. Instead, it acts as a safe protective housing for your bone marrow. Which perfectly brings us to section 3, medullary cavity and marrow. Right down the center of the bone shaft, there is a hollow space called the medullary cavity. And what's wild here is how the function of this space actually shifts as we get older. Inside this cavity and tucked within the spongy bone is your bone marrow. There are 2 distinct types. First is red bone marrow. Think of this as a bustling factory. It's the site of active hematopoiesis, meaning it's constantly pumping out your red blood cells, white blood cells, and platelets. When you're a kid, almost all your marrow is red. But as you grow into an adult, a lot of the marrow in that central shaft, the diaphysis, swaps out for yellow bone marrow. Yellow marrow is primarily adipose tissue. It serves as a vital energy and fat storage reserve for your body. Next up, section 4. Blood supply and nerves. You might think of bones as dry and static, but they are highly vascular, living organs. The main gateway for blood is a small opening in the diaphysis called the nutrient foramen. A major vessel, the nutrient artery, passes right through this opening to supply oxygen to the marrow and inner bone. And tracking right alongside those blood vessels are nerves. Here's something really interesting. Nerve endings are highly concentrated in the outer periosteum. That is exactly why breaking a bone hurts so unbelievably much. Finally, right on the ends of the bone, articular cartilage caps the epiphyses to keep joint movements totally friction-free. But because this cartilage lacks a direct blood supply, it heals very poorly if it ever gets injured. Let's tie this all together in section 5, essential clinical correlations. Let's anchor our knowledge of the diaphysis to reality by looking at what actually happens when a long bone breaks. Fracture healing is a miraculous 4-stage process where the bone repairs its own damaged cortex. Step 1 happens within hours to days, hematoma formation. Because bones have a rich blood supply, a fracture causes bleeding, which pools into a clot or hematoma. Step 2 occurs over days to weeks, soft callus formation. The body bridges the broken ends with a temporary, fibrous, cartilaginous callus. Then, step 3, hard callus formation. Over weeks to months, spongy bone steps in and converts that soft bridge into a bony, hard callus. And finally, step 4, which can take months to years. This is bone remodeling, where the compact bone is fully reconstructed back to its original shape and strength. Next is a massive clinical anchor and, frankly, a very frequent exam question: osteomyelitis. This is a severe, debilitating infection of the bone or the bone marrow. Do you remember the metaphysis we talked about earlier? That connecting zone with the growth plate? Well, in children, the metaphysis has this highly intricate, hairpin-looping vascular blood supply. The blood flow there is rich but sluggish, and that specific setup is exactly why osteomyelitis in kids so often localizes right there in the metaphysis. Our final clinical correlation brings us back to the spongy bone. You have probably heard of a bone marrow aspiration. It's a common clinical procedure where a doctor uses a specialized needle to extract red bone marrow. Now, while this is usually done on flat bones like the pelvis or the sternum, the anatomical principle is exactly the same as in our long bone. The clinician has to push the needle straight through the hard compact bone to tap directly into the spongy bone's hematopoiesis factory. Extracting those blood-forming cells allows them to diagnose leukemias, anemias, and other really serious blood disorders. All right, time to test your knowledge. Section 6, quick revision and MCQs. Question number 1. Which part of the long bone is defined as the strong central shaft? Is it A, epiphysis, B, diaphysis, C, metaphysis, or D, periosteum? I'll give you a second. Okay, if you said B, the diaphysis, you are absolutely correct. It is the tubular, central, weight-bearing pillar of the bone. Moving on to question 2. The tough outer membrane covering the bone, anchored by Sharpie's fibers, is called the what? A, endosteum, B, articular cartilage, C, periosteum, or D, medullary cavity. Think back to our outside-in dissection. The correct answer is C, the periosteum. Question 3, let's test your functional knowledge here. Where does active hematopoiesis or blood cell formation primarily occur in a bone? A, yellow marrow, B, red marrow, C, compact bone, or D, nutrient foramen? The answer is B, the red marrow, which is safely housed inside that porous network of the spongy bone. All right, question 4. Let's see if you caught the clinical correlation. What is the primary clinical significance of the metaphysis in a long bone? Does it A, store fat, B, act as the site of longitudinal growth and is prone to osteomyelitis, C, produce yellow marrow, or D, create frictionless joints? The correct answer is B. It houses the epiphyseal growth plate, and its vascular structure makes it a hotspot for bone infections in kids. And our final question, number 5. The primary blood vessel that enters the diaphysis to supply the inner bone is what? A, epiphyseal artery, B, metaphyseal artery, C, nutrient artery, or D, periosteal artery. Remember that gateway we talked about in the center of the shaft? The answer is C, the nutrient artery. Great job if you got all of those right. To wrap up this explainer today, I want to leave you with a pretty mind-bending thought. We've seen that bone isn't just a dry stick. It is a highly vascular, dynamic, living tissue that goes through constant cycles of breakdown and remodeling, like when it heals from a fracture. Because of this continuous cellular turnover, nearly every bit of compact and spongy bone in your body is slowly replaced over time. Which begs the question, are you even walking on the same skeleton you had 10 years ago? It turns out the answer is no. Your body is quite literally a constant work in progress. Thank you so much for exploring the phenomenal anatomy of the long bone with me today, and keep that curiosity alive.